This portion of CardioSource Video News is supported by the makers of Xarelto.
Welcome to day 3 of ACC.12. I'm Dr. Randy Martin with CardioSource Video News, and I've got a great panel again to talk about late-breaking clinical trials today. To my immediate left is Dr. Peter Block. Peter is Professor of Medicine and the Director of the Structural Heart Program at Emory University Hospital. And next to Peter is Dr. Deepak Bhatt. Deepak is Associate Professor of Medicine at Harvard and also the Chief of Cardiology at the Boston VA. Thank you both for joining us.
Thank you.
So, Peter, tell me a little bit about coronary, the first trial.
Well, late-breaking trials today are interesting. The coronary trial is a surgical trial, and the bottom line of the surgical trial is off-pump surgery better than on-pump surgery? And the short answer is no difference, it turns out, Randy.
Okay.
It's actually a very interesting trial. It's not as simple as all that, and as always, when you look deeper into these surgical trials, you have to ask questions about recurrent operations, bleeding, what are the pulmonary complications, and so forth. So what we learned from coronary is that if you have off-pump surgery, the chances of you needing another revascularization, another operation, are slightly higher because it isn't quite as good. The surgeon can't do quite as good a job the first time around. But the numbers are really small.
Very small.
That number one, but you have less pulmonary complications, less renal failure, and less bleeding, perhaps no surprise. So when you put it all together and lump all the off-pump problems and all the good stuff about off-pump and all the on-pump problems and all the good stuff on on-pump, it washes out as being even. So pretty much it's dealer's choice. And I was thinking to myself as I was listening to this, if I was going to have a coronary bypass operation, would I want to have it off-pump or on-pump? And the answer is, probably doesn't make any difference. I think it depends on the surgeon.
Yeah, absolutely.
Yeah, and I think being a surgeon that does a lot of off-pump surgery and is good technically, that's the way to go. But if you have somebody who's not good off-pump and good on-pump,
To do it all.
why not?
Deepak, what are your thoughts?
Yeah, I agree with that completely. It really is dealer's choice, and in contradistinction to some prior observational single-center series, it's not the case, at least in this multi-center trial, that off-pump is better than on-pump. So it's not the huge advance that, as sometimes is the case, observational data just exaggerated any potential benefit. But I think for the right patient, in the right surgeon's hands, it's an option. So somebody that's really high risk, maybe of renal dysfunction, maybe off-pump would be better. Though in a patient who might be at really high risk for pulmonary complications, might even throw out multi-vessel PCI if appropriate, could be yet another option, albeit not studied in this trial.
But I think the important lesson from this, for me anyway, is that not all surgeons should go and learn off-pump surgery. It's
Right.
not necessary.
Right, that's a
And
very
Peter,
important point.
just quickly, because we want to get to the next study,
Yeah.
do you remember whether there was a difference in vessel? In other words, was revascularization more necessary in posterior vessels versus anterior vessels?
You
Did
know,
they go into that?
They didn't go into that, so I can't give you that answer.
You would think, from a technical standpoint, you'd think that. So, okay, and interesting. Deepak, tell me about, there was another study that was quite
Yes.
interesting.
Well, sure. It's been controversial what the role of CT angiography should be, and the ACRIN study, I think, nicely addressed the potential role of CT angiography in rather lower risk patients presenting to the emergency department with suspected acute coronary syndromes. So these patients were randomized to either get a CT angio or traditional care. It was only 5 sites, but still multi-center and randomized. And bottom line, what the investigators found was that the CT angio approach was safe in terms of no excess risk of deaths or myocardial infarctions in the patients that underwent that approach to imaging. And in terms of efficiency, it appeared to be more efficient. That is, shorter length of stay, earlier discharge from the emergency department. So a win, I think, on safety and a win on efficiency in this rather proscribed patient population. Still doesn't answer the million-dollar question of whether it improves patient outcomes. That would require a longer follow-up, larger number of sites.
Absolutely.
Yeah, but they actually did pretty well with the outcomes. At 30 days, I was impressed. The thing that always worries me about just doing a CT and sending a patient home, even a low-risk patient, is there's always going to be somebody that walks out of the ER and drops dead, right?
Right.
And the lawyers love that. So how do we avoid the lawyers not loving us for that? And I think the answer is it's less than 1% of these patients that had 30-day MACE. And that's comforting. Now, the other side of this, of course, is that they're very low-risk patients.
Yeah.
They chose low-risk patients, and consequently, that's a little bit of an issue that pushes this towards safety.
Do you think this is going to influence practice? I mean, or is it? I mean,
I think
in
it's
your hands or in your hospitals?
Well, I think it's center dependent, and that's an important
Right.
part. These were 5 sites that are really good at CT angio. So again, larger studies would be needed to show that it's generalizable, but it's like the surgical results. In the right hands with a good radiologist, I think CT angio in this relatively low risk population is indeed safe and may enhance efficiency.
Okay, well that's great thoughts, and you know what? We will have more late-breaking clinical trials in just a minute, so we want you to stay tuned, and we'll be right back.